Good evening, everyone. Thank you for joining. My name is Naima Joseph. I am a maternal-fetal medicine physician here at Beth Israel Deaconess Medical Center, and I'm presenting today on updates on vaccination and pregnancy. Because it's a webinar, I can't see anyone, but please feel free to drop suggestions, comments, questions in the Q&A. And Erica is here moderating, so if anything sounds like it should be addressed in the middle of the presentation, I'm happy to do so, but otherwise we'll save question and answer for the end of the topic. So my goal today is to kind of discuss, obviously, vaccination and pregnancy because vaccination remains below targets globally. And there are many reasons for that, but this does represent an opportunity that's missed given the dual benefits of vaccination for providing both maternal and infant protection. And so my objectives are for you all to understand the rationale and concepts for maternal immunization, for you to realize the clinical importance, the known benefits and safety of select vaccines during pregnancy, to know what's currently recommended regarding vaccination during pregnancy, to be familiarized with key issues, opportunities, and challenges, especially the lessons that we've learned since the COVID-19 pandemic. And ultimately, and this is probably a larger ask, but to be equipped to provide evidence-based recommendations for vaccines in pregnancy. I have no relevant financial disclosures. I wanted to start by saying that, as we know, pregnancy does pose an increased risk for maternal morbidity and mortality from infectious illnesses. And a lot of that is because of what's known as the immunogenic paradox, where pregnancy is characterized by a combination of physiologic and immunologic changes that are important, obviously, to maintaining immunologic tolerance towards the fetus, but unfortunately do lead to a period where the pregnant person is at enhanced risk for both new infection acquisition, worsening disease severity, if the disease were to occur in pregnancy compared to not in pregnancy, and then certainly at higher risk for adverse fetal outcomes as well. There's also an enhanced period for childhood morbidity and mortality within the neonatal period. And again, passive immunity through transplacental antibody transfer and secretion in breast milk can address what the etiologies are for this neonatal vulnerability, which include, first, that the neonatal immune response is immature, and so neonates are unequipped to efficiently address infections in that time period. Second, there's neonatal immunologic blunting, which means that passive maternal antibody transfer does in fact lead to or contribute to further decreasing the response to new infections that the neonate might face. And certainly part of this is intentional in that neonates are born and are really quickly exposed to a variety of new infections, both just through the birthing process and then immediately in the first months of life. And then third, that vaccines really have not been shown to lead to any efficacy when given in the first 2 months of life, up to 6 months of life, such that there's a window where they remain vaccine ineligible. So we know that vaccine-induced immunity can protect both mothers and their infants against infection and severe disease, given that we know that vaccine-induced compared to natural-induced immunity does lead to a stronger immune response, which obviously enhances the protection afforded by vaccination, but also leads to enhanced transfer of antibodies across the placenta and in breast milk. And so ultimately, maternal immunization does present an opportunity to optimize long-term maternal infant well-being. And there are many opportunities that exist during pregnancy and in prenatal care. There are some early milestones in maternal immunization, first in the late 1800s, where vaccinia was demonstrated to show some protection against mothers and infants from smallpox. And then in the 1940s, initial studies of whole cellular diphtheria, tetanus, and pertussis in the United States was shown to effectively almost eliminate diphtheria and tetanus infections. Finally, the influenza vaccine was shown to protect women against the 1957 pandemic. And then certainly more broader inclusion of tetanus vaccination globally has been shown to reduce maternal and neonatal tetanus. And I just want to delve into these a little bit more further. So first, maternal and neonatal elimination of tetanus really paved the way to demonstrate that vaccination could be a low-cost and effective strategy to prevent maternal and infant deaths. Essentially, maternal and neonatal tetanus was associated with an 80 to 100% case fatality, with the burden of deaths much higher in the first 6 months of life. In the 1960s, as I mentioned, the WHO did include tetanus toxoid vaccine to global vaccine efforts, and that did lead to a decrease in neonatal deaths, but still in 1980s, the tetanus still accounted for close to 800,000 deaths worldwide, or represented about 30% of total infant mortality. With the Millennium Development Goals, there was a push towards skilled birth attendants, umbilical cord care, and increased neonatal tetanus surveillance that did contribute to a reduction in deaths, but still the deaths remained over 200,000. And so there was a push to implement TT2+ in 59 priority countries in the 2000s. So TT2+ basically represents the fact that during pregnancy, women are given 2 doses of tetanus toxoid vaccine, in addition to the existing strategies such as skilled birth attendants and clean cord care. And what you can see here is that following the introduction of TT2+ coverage, with sustained coverage above 70%, there's a dramatic reduction in neonatal tetanus deaths in 45 of those 59 countries. Pertussis also is an example of where we've had success in immunization. As you know, Bordetella pertussis is the respiratory pathogen that's responsible for the whooping cough. It has many names, including the 100-day cough or the kink. But essentially that is reflective of its pathogenesis, which is that it's a bacteria that does produce a toxin that does paralyze the ciliary epithelium. And essentially, prior to the introduction of the whole cellular vaccine, it was a leading cause of childhood deaths and responsible for at least 80% of deaths, 300,000 childhood deaths, 80% of whom occurred before 4 months of life. Once the vaccine was introduced, the incidence dropped again dramatically from 156 per 100,000 to 2 per 100,000 deaths. However, there was an outbreak in 2012, which was caused by many things. Most notably because of what was found to be waning immunity in adolescents and adults. This is because certainly there was enhanced surveillance at this time, increased case detection, but there was this observation that the whole cellular vaccine was associated with this period of prolonged crying, febrile convulsions, and rarely hypotonic hyperresponsive episodes in infants, which became sensationalized in a documentary put forth by what's now known as the National Vaccine Information Center, which remains to this day a leading cause of vaccine misinformation, but essentially did lead to high-income countries to switch from the whole the cellular vaccine to the acellular vaccine, or DTaP. And this was actually shown to be less effective, but also less reactogenic. And so in high-income countries, DTaP replaced whole cellular vaccination. Unfortunately, what was seen was that in infants who did develop infection and had died, 60% of them did have exposure to an infected parent, which suggested that the current strategies to improve vaccination in adults was not working. So prior to the peak, the strategies consisted of cocooning, which meant that the postpartum parent or all household contacts received the vaccine, and that the infant received vaccination within the 2 months of life, or beginning at 2 months of life. In 2011, the United States was the first country to recommend vaccination during pregnancy, and almost immediately there was a noticeable reduction in infant cases, such that in 2012, essentially 6 months from that first recommendation by ACIP, there was a unanimous, which is like rare for the CDC, but a unanimous recommendation for pertussis vaccination to be provided in every pregnancy. And as you can see here, vaccine effectiveness was measured, and what was initially demonstrated was that in infants who were born to moms who had gotten the vaccine at least 28 days before birth, or in the 7 to 27 days before birth, there's about a 91% vaccine effectiveness and protection from incident infection. Whereas infants born to moms who had received the vaccine within the week before birth or postpartum, there was only 38% effectiveness at that point. Also, smaller series showed that infants who were born to moms who did develop vaccine also had much reduced morbidity, including low risk of seizures, low risk of intubations, low risk of deaths. And finally, a decision analytic model showed that when vaccination was provided in pregnancy, which is this line here, that there was the lowest incidence of infections occurring in the first 2 months of life, which again was the time period where infants were most likely to have infection and most likely to get sick. So this was critical and led to recommendations that the Tdap vaccine should be offered in every pregnancy. And even more recent data have shown the sustained response where this implementation of universal vaccination in every pregnancy has led to dramatic and sustained reduction in infant pertussis hospitalization rates. So now ACIP recommends that the Tdap is administered at 27 to 36 weeks in every pregnancy, unless there's been a prior anaphylactic allergic reaction to a dose. You can offer it postpartum if the adult has never been vaccinated, but if the person was vaccinated in the last pregnancy, then there's really no indication to offer it postpartum. You can also offer it prior to 27 weeks based on local outbreak or risk for exposure. And again, want to emphasize that other than anaphylaxis, there's really no reason that patients should not be immunized every pregnancy. And then finally, with the flu, which we know is an RNA virus that has A and B serotypes, and it undergoes antigenic shift and drift annually that leads to endemic and pandemic flus. It's a seasonal virus, usually occurs in the fall through spring, but does have 2 peaks in October and February. And as you also know, there have been at least 3 notable pandemic influenza pandemics, but the most notable were in 1918 and 1957. If we compare the 1918 pandemic influenza, that was responsible for 50 million deaths worldwide. And at the time, the recommendations were to wear a mask, to live a clean and healthy life, to respect quarantine, to avoid crowds, to not neglect the mask, considerations that are still appropriate for today. But then in 1957, the pandemic was associated with 1.1 million deaths. And a lot of this was because of the rapid implementation and introduction of a vaccine. So essentially, following the 1918 pandemic, the influenza virus was isolated, and a vaccine was developed essentially within 4 to 6 months of recognition that there was a pandemic. And that has led to current recommendations that influenza be administered seasonally every year. And then the third pandemic, which is notable, was pandemic H1N1 in 2009, because it was the first to really demonstrate the unique threats in pregnancy that can occur following respiratory infections. There were fetal complications that were noted, which included risk of stillbirth, miscarriage, preterm birth, and neonatal death. But maternal threats were appreciated in that the first reported death was in a pregnant patient. 5% of all influenza deaths occurred amongst pregnant patients, who represented about 1% of the total population at the time, and 22.6% of all admissions were also among pregnant patients. The effectiveness of vaccination in protecting both mothers and their infants was well demonstrated in 3 randomized trials that were global and multi-site and multi-center, essentially showing that maternal immunization was associated with a 50 to 70% reduction in disease severity, and that also up to 6 months postpartum, but also that there was a neonatal benefit and that there's a 68% reduction in infant hospitalization as well. And so this kind of catalyzed the understanding that vaccination in pregnancy provided both maternal and neonatal benefit. And led to recommendations, certainly for flu, that the flu vaccine be administered seasonally every year, ideally based in September through October, but up until flu transmission, which can be as far into May. It should be administered any trimester in pregnancy, so people should not delay until the 3rd trimester to provide the flu vaccine. The caveat is that if someone is in their 3rd trimester, in July and August, you can offer flu vaccine if it's available to enhance passive immunity to the neonate. And then again, really no contraindications. Those with egg allergies, a history of Guillain-Barré should be offered flu vaccine, but monitored in a healthcare setting. And then most recently, a COVID-19 disease in pregnancy, as we all know, is associated with higher risk of adverse outcomes in pregnancy, including an increased risk for ICU admission and maternal death, poor obstetric outcomes, stillbirth. Although earlier in the pandemic, the recommendations, there were not yet strong recommendations for vaccines, given the earlier lack of data. Now the data are really overwhelming that it is a safe strategy to reduce the maternal and neonatal morbidity from severe COVID-19 disease. This was one of the first studies that looked at the immunogenicity and the reactogenicity of vaccination and showed essentially with both the mRNA vaccines that the difference in reported pain, fatigue, fever, et cetera, was not different in pregnant compared to non-different pregnant patients. That the risk of miscarriage was not enhanced in those who had received vaccine. That vaccination did afford benefit in that those who had received vaccine compared to those who had not received vaccine had lower incidence of cumulative infection over time, and therefore, of course, lower risk of severe disease, hospitalization, and death. And then finally, most recently, that there was a benefit for infants as well, in that infants who were born to unvaccinated mothers compared to those born to fully vaccinated mothers had higher risk of ICU admission, critical disease, mechanic ventilation, and other invasive support. Unfortunately, the COVID-19 vaccinations are not as straightforward, but currently the current landscape is that there are 4 approved vaccines that are approved or authorized in the United States. There are 2 mRNA vaccines made by Pfizer and Moderna. There's a viral vector vaccine, or the J&J Janssen vaccine, and then there's a protein-based Novavax vaccine. You're considered up to date with COVID-19 vaccination if you've completed the primary series and, really vaguely, if you've received the most recent booster dose recommended for you. And so what does that mean? Essentially, for an mRNA vaccine, these are basically recommended as a 2-dose primary series that's given 8 weeks apart. You can give the Pfizer vaccines 3 weeks apart, and you can give Moderna as close as 4 weeks apart, but just standardize this primary series, 2 doses, 8 weeks apart. Earlier with the, when Alpha and up through Delta were the dominant variants, monovalent booster was recommended, especially for those who had higher risk for severe disease based on age and immunocompromising condition. But now with the rise of Omicron, bivalent boosters recommended after completion of any of the primary series for those 6 months and older. You're considered up to date if you've completed 2 doses of an mRNA primary series plus a bivalent booster given at least 2 months from that second dose. And then there is this opportunity for monovalent boostering with Novavax vaccination, again, when given 2 months from that, the second dose of the primary series. mRNA vaccines are considered preferential for use in pregnancy. The next vaccine is the J&J Janssen vaccine, which is available as a single-dose primary vaccine. Also available as a single-dose booster after completing the primary vaccination for those who are age over 5 years and immunocompromised. And there was a recommendation for heterologous single-dose booster following completion of the primary vaccine, which is no longer recommended. You're considered up to date if you've received a single dose J&J with a bivalent booster of an mRNA vaccine at least 2 months from that J&J dose. And it should be noted, as many of you are aware, given the reports of thrombosis with thrombocytopenia syndrome that tended to occur most frequently in females of reproductive age, that this is preferentially administered to males age 18 and older, or for those people who are unlikely to complete a 2-dose vaccine. So meaning if there's a patient that presents opportunistic screening in triage or in the emergency department, homelessness, et cetera, where there's an opportunity to provide just 1 dose of vaccine, then that's the preference. And then most recently, the Novavax vaccine is available, which, as I said before, is a protein-based vaccine, which is more like a traditional vaccine. This is available as a 2-dose primary series offered 8 weeks apart. The first booster should be administered after completing primary vaccination for those who are over the age of 18 and immunocompromised and essentially unable to receive the mRNA vaccine. So you're considered complete if you've received 2 doses of the Novavax primary series plus a bivalent mRNA, or if you've completed 2 doses of the mRNA primary series and a monovalent Novavax booster. So this is one where mixing is advised. And by unwilling or unable to receive the bivalent booster, it's that you're age over 18, you've not received a prior booster dose, and for whatever reason, you've decided that you're unwilling, or if there was a severe reaction to the mRNA vaccine. So the recommendations are vague, but ultimately COVID-19 vaccine is recommended for all pregnant persons. Essentially all people should complete a 2-dose primary series followed by a bivalent, ideally a bivalent booster, at least 2 months from completion of that primary series. And again, there's no reason to delay due to 3rd trimester of pregnancy. Some vaccine quick facts, as I mentioned, and I'm just harping on influenza, Tdap, COVID-19, routinely recommended during pregnancy. But prenatal care does present an opportunity to discuss other vaccines in the context of the person's own risk for exposure, risk for severe disease, or poor pregnancy outcomes. In general, vaccination in pregnancy is safe. The most commonly reported adverse outcomes are local erythema and swelling. Risk for miscarriage and birth defects have never been reported following vaccination. And then there's a theoretical risk regarding live vaccines, but they're not considered contraindicated per se in pregnancy. For instance, yellow fever live vaccine can be offered in pregnancy if someone is going to an area with high transmission. The guidance do say that you should delay pregnancy if you've received a live vaccine by about 4 weeks. But ultimately, persons who do receive a live or a live attenuated vaccine in pregnancy don't necessarily need to be counseled to terminate due to teratogenetic risk. Again, the following are not contraindications in general to vaccination: pregnancy or breastfeeding. For most vaccines, pregnancy or breastfeeding are not contraindicated. Presence of a low-grade fever, prior non-severe, so non-anaphylactic, severe immunization reaction, a history of allergy to egg, neomycin, streptomycin, as many of the vaccines have now been reformulated. Receipt of multiple simultaneous vaccinations, meaning that Tdap, COVID can all be administered on the same day, as long as you keep track of what dose was provided in which limb to monitor for reactions. And then history of Guillain-Barré syndrome following a vaccine. And so, this is a little tricky in that GBS was most often linked with flu vaccine before. It was associated with about 1 case per 100,000 doses of swine flu vaccine and 1 to 5 per million doses of H1N1 vaccine. And historically, these were noted within 6 weeks of getting an influenza vaccine, but simultaneously, persons who had swine flu or H1N1 who had natural infection were also noticed to have higher risk of group B strep. So currently, what's the recommendation is that there's a precaution for people who have gotten Guillain-Barré syndrome within 6 weeks of their flu vaccine, and that essentially it's your decision-making process. The individual and their doctor should consider the potential for risk and benefit regarding any dose of influenza vaccine. So for instance, if someone is immunocompromised, has pulmonary conditions, pregnancy, that person may actually benefit from influenza vaccine and may take the risk of recurrent GBS, whereas someone who works from home, has really low risk of community exposure, otherwise healthy, may decide that influenza vaccination is not for them. For people who have had GBS, Guillain-Barré syndrome, from any other cause, they can still receive the influenza vaccination. And then also, household contacts should be counseled on vaccination to promote cocooning immunization, kind of similar to herd immunity. So that means that partners or patients should be counseled that their partners should get Tdap, influenza, et cetera, to improve safety and immunity for the infant. And again, to harp on addressing the safety concerns, really few and rare adverse events have ever been associated with any vaccines. And this was a really nice systematic review of all vaccine adverse events reported from randomized trials and from effectiveness data that was published in The Lancet opportunistically right at the onset of the COVID-19 pandemic. So anaphylaxis, it's associated in 1 dose per almost up to 1 million vaccines received. Mild arthralgias, tends to occur in about 10 to 25 per 1,000 vaccines administered to females. Deltoid bursitis can occur, but usually associated with administration that's done poorly or incorrectly. Febrile seizures can occur in infants prior to 5 months. Thrombocytopenia is rare and has been reported following receipt of the MMR vaccine. And syncope can occur. As I mentioned before, the thrombosis with thrombocytopenia syndrome was seen in 3.83 per million J&J vaccine doses given, with a rate of about 2.83 per million when given to females, hence the preference given to males. And so there are 4 vaccines, as I said, recommended in pregnancy, but this does leave a lot of other vaccines that can combat preventable illness and presents an opportunity for counseling, especially at a time when women are engaged in care and have the opportunity, therefore, to screen for immunity and eligibility of routine vaccines. So there are some guiding principles for vaccine administration kind of in or surrounding pregnancy. Essentially, as I said before, considering the risk of exposure of the disease, whether infection poses a special risk to the mother or to the fetus, and whether or not obviously a safe and effective vaccine is available and unlikely to cause harm. And that risk of harm, it can be specific to that person and their prior kind of vaccine reaction versus in general harm from vaccines that's more globally known. And so the pandemic has taught us a lot about lots of things, but I wanted to think about 3 main tenets. One is that there have been missed opportunities that I think we didn't realize, but have been demonstrated to capitalize on prenatal care to enhance long-term maternal infant wellness within vaccinations. And I think one of the most exciting papers I saw in the pandemic was actually related to hepatitis B vaccination in pregnancy as a missed opportunity. This was a paper that was published by Malavika Prabhu and in the Green Journal in 2020. And essentially, the rationale was that acute hepatitis occurs in 1 to 2 per 1,000 pregnancies with kind of rising rates, that acute hepatitis is associated with acute liver failure, but then also downstream a 10 to 20% risk of chronic hepatitis, which therefore can be associated with fulminant liver failure, cirrhosis, need for transplant, but also that there is a risk for perinatal transmission. And essentially there's this inverse relationship where the younger you are at infection, the higher the risk is of developing long-term chronicity of hepatitis B, such that children are at the highest risk of long-term chronic hepatitis when infected perinatally. Second, there's the availability of a safe vaccine that's been demonstrated overwhelmingly to be safe in pregnancy and as well as effective in that the routine series has shown efficacy that's similar to non-pregnant patients. And that currently hepatitis B immunity is really offered after a risk-based screening approach, in that the recommendations had been to screen patients who had risk factors such as sexual exposure, injection drug use, percutaneous or mucosal exposure to blood, travelers to or from countries with high endemicity, hepatitis C infection, HIV infection, chronic liver disease, or incarcerated. And so what Prabhu and colleagues did was essentially conduct a cost effectiveness analysis that looked at an approach where everyone was screened for immunity during pregnancy. And they found that that universal screening did lead to, and vaccination when appropriate, did lead to 1,700 fewer cases of hepatitis B, which led to 7 fewer cases of decompensated cirrhosis, 4 fewer liver transplants, and 11 fewer deaths without a huge burden of cost. Currently, ACIP and the American College of Physicians consider universal screening as a best practice during pregnancy, but the American Academy for Liver Disorders does recommend routine screening in pregnancy. This is under review at the CDC, as well as SMFM, who are kind of reviewing their latest guidance around hepatitis B. And the draft that was up for public review most recently stated that persons without documentation of a complete vaccine series should undergo universal screening for the 3-test panel, and vaccination should be offered in non-immune. And really, this can be done routinely unless there's documentation of immunity in the past, or they have had triple screening in the past. But this does raise the option for other vaccines, which I think for the most part we do pretty well, specifically for varicella. That's routinely screened. Immunity is routinely screened during pregnancy. Hepatitis B would follow that approach. And for those that are identified to be non-immune during their pregnancy, then counseling is provided during prenatal care with a plan to initiate the 2-dose series in the postpartum period. Again, as a reminder, the varicella is a 2-dose series that's given in the adult population 4 to 8 weeks apart. The first dose can be given postpartum in the inpatient setting, and then there are lots of opportunities to get the second dose in either cocooning with pediatric visits. There are some pediatricians who do offer adult catch-up vaccines. Second dose can be prescribed to the pharmacy, or depending on availability within local clinics provided at postpartum visits. And this is the list of contraindications, essentially anaphylaxis, blood dyscrasia, cellular immunodeficiency, including AIDS, and then a current mild or severe illness in pregnancy. And similarly, the MMR vaccine, which is a single-dose vaccine, which we screen for routinely during pregnancy, can be offered to as a 1-dose postpartum vaccination and really kind of capitalize on the screening that's done during pregnancy. Just note that 2 doses is offered if the person is a healthcare personnel or traveling to an area with high endemicity, and that the contraindications do include receipt of a blood transfusion within 3 months, so special consideration in our patients, and that is out of concern for kind of ongoing blood dyscrasia following receipt of the vaccine. However, there have been studies in transfusion-dependent patients who have received MMR vaccine that have not shown enhanced risk for bleeding and that have shown no difference in immune response. I think another kind of lesson learned following the vaccine, the pandemic, is the potential for novel vaccine technology to address gaps currently in vaccination. And essentially, before the pandemic, most vaccines were used traditional vaccine platforms, which included the virus-based vaccines. Those are whole inactivated or attenuated virus vaccines, such as MMR, polio, intranasal flu, which are considered not appropriate for use during pregnancy. And the protein-based vaccines, which essentially are derived from a protein that's purified from the virus or a virus-infected like cell, for example, the seasonal flu, or are derived from structural and non-structural viral proteins that are used to form the viral particle but lack the genome, such as the HPV vaccine. Essentially, before the pandemic, the throughput from identifying a candidate kind of polysaccharide to developing vaccine to licensure took about 10 to 15 years. But with increasing vaccines and the use of kind of novel DNA plasmid vaccines, there was significant reduction in availability of vaccines with the first onset or recognition of a potential infectious threat and pandemic level threat. Such that with Zika virus in 2016, the first kind of vaccine trial was performed about 3 months after recognition of the burden. So now I think we're all kind of well aware of these genetic sequencing-based vaccines, essentially that contain antigens that are coded by DNA or mRNA and delivered by a viral vector or non-viral delivery system. They don't generate a de novo immune response, but rather provide immune-mediated protection through delivery of antibody-coding genes. For example, the COVID-19 vaccine, which encodes for the spike protein, which is the most immunogenic part of that virus. There are many vaccines that are under investigation that are using this novel platform, including for HIV, for influenza, for Zika, for cancers, and for some autoimmune conditions. But it does provide potentially some opportunities for those infections in pregnancy that are at enhanced risk, for which we don't have a readily available vaccine, such as for group B strep, for respiratory syncytial virus, and for cytomegalovirus. And I just wanted to take a step back to consider where we are with group B strep, and essentially that it is the leading cause of severe bacterial infection and sepsis in the first 3 months of life. Neonatal acquisition typically occurs intrapartum from a colonized birthing parent, and colonization is as high as 40%. And currently the strategy is for universal screening during pregnancy at around 35 to 36 weeks, intrapartum antimicrobial prophylaxis during labor with penicillin and ampicillin based on kind of local coverage and vaccine and antimicrobial properties. But however, that approach does fail to address the stillbirths, the immediate neonatal sepsis, the late onset disease, and the invasive maternal disease that occurs. And this is essentially demonstrating that despite the introduction of this universal screening strategy and the use of intrapartum antimicrobial prophylaxis, that early onset disease did drop dramatically, but that there's still persistent late onset disease and still kind of persistent infection in pregnancy. And this is an area where vaccination could potentially be beneficial. There was a really promising study in 2003 done by Baker that essentially used the group B strep polysaccharide, which is the immunogenic portion of that bacteria, kind of within a tetanus vehicle, and did show the ability of that vaccine to induce IgG-specific response in moms and in the newborn, initially and at birth. However, there have just been no further kind of efforts to further investigate and develop new vaccines. A recent analysis by the World Health Organization and the London School for Tropical Health and Hygiene showed essentially that if you could get GBS coverage at about 70%, you could avert 50,000 GBS deaths, 170,000 preterm births, and essentially lead to a $17 billion benefit over several years. And so there is some advocacy and some kind of public demand for this vaccine, but still uncertain where this is in terms of production. Another opportunity is with respiratory syncytial virus, which, as you know, is the dominant cause of hospitalization in infants with lower respiratory tract infections. In 2015, it led to 3.2 million hospitalizations, 118,000 deaths, the majority of which happened in infants prior to 6 months. There is no current RSV vaccine. And a recent trial that looked at an RSV nanoparticle vaccine, again using a kind of traditional platform, failed to meet its a priori endpoint of 37% vaccine efficacy. And these are my twins at 28 days of life when they were admitted with RSV. And so certainly, you know, this obviously is personal, but many parents would, you know, gladly accept a vaccination that would reduce their kids from being hospitalized. My kids are fine. And then finally, congenital cytomegalovirus remains, you know, a quote unquote silent burden. It is the most frequently transmitted vertical infection, occurring at a rate of 0.5 to 0.7% in pregnancies in high resource settings, but 2% in pregnancies in low resource settings. But even if you look at the math, if you have 100,000 moms in a quote low seroprevalence setting, 1% risk of infection with new infection, you still end up leading to about 1,000 newborns that are born with congenital CMV annually. And in the United States, in fact, there are 40,000 infants that are born every year with cytomegalovirus. The risk of congenital or perinatal transmission is 40%, especially with primary infection. But essentially the sequelae associated with huge morbidity, including risk for stillbirth, perinatal death, neurocognitive delay, seizure disorder, and deafness. And this is a disease for which there's no currently approved treatment, although there are several under investigation. There have been attempts at vaccine trials, again, using traditional based platforms. There have been at least 3 trials looking at the 3-dose CMV glycoprotein B vaccine, which have shown essentially 43 to 50% efficacy against primary infection. And the challenges are manifold, but one is that the mechanisms driving immunity are not clear. Again, primary immunity or secondary immunity doesn't protect you from reinfection because it's a herpes virus. It can kind of stay hidden in the system for a long time. The clinical endpoints have not been well defined. You know, are they looking at preventing infection versus if you get infection, but you have vaccine-induced response, maybe just prevention of disease should be in the endpoint, but with a rare outcome, hard to study. And then finally, the idea that sterilizing immunity, meaning just looking at persons who have had no pre-existing immunity, may be challenging, especially as pre-existing innate immunity is not necessarily protective. There is an ongoing phase 3 quadruple blind randomized trial using a novel vaccine platform, the mRNA 1647 CMV vaccine. That gave its first dose in December of last year, I believe. So this is a 3-dose vaccine that's currently enrolling women for age 16 to 40 years, especially because that would be the population that would most benefit from receipt of this vaccine. And the primary endpoint is seroconversion and adverse events. So that trial is expected to complete in 7 years. But there are many, many more opportunities for immunization to protect pregnant women and their infants against meningococcal, pneumococcus, herpes simplex virus, Zika virus, malaria, and HIV. And then another lesson is obviously that equitable vaccine allocation is really foundational to success. We saw this with the COVID-19 vaccination efforts, in that despite higher risk of COVID-19 mortality, the vaccination rates were lowest in Black birthing patients. This was a study done by Eugene de Klerk that looked at maternal mortality before and after the pandemic. And as we know, Black birthing persons have the highest rate of maternal deaths, but it increased 33-fold during the COVID-19 pandemic. And this is our own institutional data that basically showed that Black birthing patients have the lowest rates of vaccination, but fortunately, that over time vaccine intent does seem to change, and that vaccine hesitancy seems to be the most malleable in that population. When we look at trends in kind of prenatal vaccine coverage for Tdap, for influenza and Tdap, with the light blue being 2019-2020 and the dark blue being 2017-2018, overall, the rates of vaccination for both influenza and Tdap are increasing across all minority populations. But still in 2020, only 40% of pregnant persons had received both the recommended vaccines. And still we're seeing the huge disparity in vaccine acceptance and uptake in Black patients and in Hispanic patients, who of course face the highest rates of maternal mortality, with the change in, or the rate of change, increasing substantially in this population, as well as increased rates of infant mortality as well. So this does present essentially low-hanging fruit to improve vaccine preventable death in a really socially vulnerable population. So I think in general, need to capitalize on novel vaccine platforms, need to improve confidence about maternal immunization amongst the public. And I didn't get into this, but also providers, as that contributed to some hesitancy with the pandemic, and need to improve equitable vaccine delivery, amongst many, many other lessons. But I wanted to transition that to sort of the efforts that are being done here at BIDMC. I think first I wanted to recognize that how to provide vaccination during prenatal care is not well studied. There's not an approach that is really evidence-based and informed. And so one of our maternal-fetal medicine fellows, Dr. Bridget Donovan, is conducting a systematic review on best practices for vaccine counseling and provision in pregnancy, in hopes to answer some of the questions around what is the best way to deliver vaccine during prenatal care. And then there is a COVID-19 department task force that was developed prior to the changes from the Joint Commission and CMSS regarding organizational targets for reducing healthcare disparities, specifically looking at one item and how, like, developing written plans for how to address health disparities within our department, and providing dashboards and data to support where the gaps in equity are and how we can address those within our population. So there are a lot of equity efforts within the department, but COVID-19 vaccine, addressing that is one of them. And the first, and this was before I started, the first was to, and this was led by Dr. Chloe Zara, the first was to just first start tracking what the vaccination rates were in our population. So at the start of this, we were capturing about 7% of total vaccination rates, and respondents were simply asked to answer yes or no to whether or not they'd received a COVID vaccine, and then over time got to about 7% missiveness, and it's even lower. The data initially showed that what we would expect, in that if kind of global coverage rates is about 90%, we in general do really well at making sure our patients are vaccinated, but that we still lag behind in that our Black patients are still under-vaccinated in comparison to their non-Black counterparts. We did engage stakeholders who primarily take care of our predominantly socially vulnerable groups, from practices like Bowdoin, Chelsea, Dimick, to help us understand what the vaccine practices were in our institution at those clinics, and to help us understand how to reduce disparities in our pregnant and postpartum patients. And essentially, this initially consisted of conducting interviews that I did along with Martina Dayhill to ask our providers at these clinics what the process was for identifying unvaccinated or undervaccinated individuals in the practice, what providers identified as their barriers and facilitators to getting patients vaccinated, to understand how vaccination status was even measured and tracked, and obviously to ask for advice, given that a lot of these providers had been members of the community and part of the clinical community for a very long time, and had really unique relationships with their patients. Essentially, this kind of led to analysis that showed that amongst the environmental barriers was that vaccination wasn't really readily provided within the clinic sites. And so there were some missed opportunities in that patients who were ultimately ready to be vaccinated were not able to, had varying ability to get same-day vaccination, which ultimately contributed to kind of loss of kind of lack of follow-up on behalf of the patient to get their vaccine. And so we as a group came back and thought about, well, what are some things that we can do to address a lot of the kind of needs and barriers that were elicited from from those interviews, and developed a prioritization matrix. But what ultimately came out of it was a creation and development of patient educational tool staffs, hosting of Ask the Expert series, Q&A sessions on providing on vaccine provision. And then now, which I'm hopeful most of you are aware of, a vaccine equity dashboard where clinics can track their own patient vaccine rates. So this is sort of what the dashboard demonstrates, which essentially shows vaccination rates by practice. And essentially, yellow represents that practice's own vaccine rates, red represents our target rates, and blue for all these represents the global BIDMC vaccination rates. And so again, you can see that for the most part, we do a really good job of making sure our patients are vaccinated, as many practices are at or above coverage, but that we still really have the lowest rates of vaccination in our socially vulnerable clinics, especially at Bowdoin, at DIMIC, and at one point during the residency practice, but that's improving as well. And so the thought was to capitalize on some patient level as well as some of the environmental and clinical level barriers by providing inpatient vaccination for our postpartum initially, and now also our antepartum patients. And I wanted to kind of emphasize that this is really unique for our department in that in the hospital to receive COVID-19 vaccination, it's not possible unless you're being discharged to a long-term care facility. And so the hospital administration really valued the opportunity and this kind of unique considerations for pregnancy, and did allow for us to provide vaccination for our pregnant and postpartum patients. And so the rationale was that, again, varying availability at outpatient clinics, patients might be more willing to obtain vaccine postpartum given concerns about pregnancy. Again, not ideal, as we want to capitalize on pregnancy for the duality of benefit, but also to help our patients in general just become vaccinated. And then they're kind of captive during a postpartum or antepartum mission where the same person can sort of review the most current data, recommendations, et cetera, and really assess their vaccine willingness. So this can be offered to our patients now, and it can be ordered through POE. Please reach out to me because I can send you the checklist to make sure that the vaccine is ordered appropriately. And this is, again, just to reduce redundancy and to reduce wastage of vaccine. Once it's ordered, it's kind of dedicated to that patient, and we're just trying to limit waste. But in summary, obviously, we need to improve globally coverage of the recommended vaccines during pregnancy, primarily through prioritizing maternal immunization as a feasible public health strategy to improve maternal and child health, but also we also need to think about missed opportunities for vaccine prevention presented through prenatal care with hepatitis B, and then in the postpartum with MMR and varicella. That there are some strategies available at BIDMC, specifically, monitoring vaccine rates on our dashboard, and then offering unvaccinated patients COVID-19 when they're inpatient, and further discussion around routine kind of postpartum vaccination bundle as well. Thank you all so much for listening and for tuning in, and I'm going to look at the chat to see if there are any, or the Q&A to see if there are any questions.
Thank you. I haven't seen any questions come in yet, but for the attendees that are on live. Oh, here comes a question. Do you see it?
Yes.
Perfect.
Okay, so the first question is, since HPV can be given safely to breastfeeding women aged 26 years and younger who have not previously been vaccinated, do you think we should offer this to our eligible postpartum patients while in hospital before discharge? Thank you. I think it's a great question. You know, the idealistic part of me is yes, but I think there's some implementation strategies that we have to think about in terms of like burden to nurses, pharmacy, et cetera, and where we prioritize the vaccines in terms of HPV, people who haven't gotten their flu, Tdap, who've never gotten Tdap, MMR, and varicella. So ultimately, yes, but I think that for implementation, just better understanding of what the priorities would be and what the kind of unintended poor consequences might be before we broadly offer that. I'll put that as answered. Okay, thank you, Divine Division. Okay, so the next question is looking at how to approach a patient who specifically declines COVID-19 vaccine because they feel like it's not new and there's not enough data yet. There have been approaches that have taken a global perspective of the evolution of data from the onset of the vaccine to where we are now. One, kind of counseling patients on the overall regulatory approach, and that there are like 6 different institutions that look at vaccine data before ultimately providing recommendations. And then 2, counseling on overall safety to moms of COVID-19 in pregnancy, of COVID-19 vaccination in pregnancy and the reduction of disease. But I think most recently, a lot of what's been motivating patients is that the data surrounding neonatal benefit, protection from disease, severity, which is relatively new, but might be motivating. Unfortunately, kind of simultaneously, we're at this point where 3 years into the pandemic, people may have already had COVID and may not be aware that still naturally induced immunity is still not as good as vaccine-induced immunity. And so that might be a talking point, or are kind of firmly entrenched in their decision to not be vaccinated. Okay, thank you. Why the upper age limit for HPV vaccine? Yeah, that's a question that's under research, but that stems back to the original eligibility criteria and when the thought that most people were likely to have HPV exposure, as it's like HPV is the most common sexually transmitted infection prior to, by age 11 to 26. So this represented an opportunity prior to exposure that you could have immunity that would protect them from long-term infection. But that's also under study. Oops, cancel. Okay, answered. Okay.
All right. Well, thank you all for tuning in tonight. I'm going to go ahead and stop the recording. But if people have questions,